Drugs for treating mental health conditions. At the end of this session, students should be able to describe treatments for common mental health disorders, define commonly prescribed medications for mental health conditions, and recognize conditions in which mental health disorders can be a secondary symptom. Patients with mental health complaints or concerns or disordered behavior present in a variety of clinical settings, such as a primary health and emergency department settings. Although these concerns are not recognized frequently in the sports medicine practice, athletic trainers may encounter athletes with complaints or concerns that may be new or a continuation of a history of mental health conditions. Athlete complaints may be related to direct or secondary effects of physical conditions, such as injury or concussion. When evaluating an athlete for potential mental illness, the athletic trainer may have to focus on more immediate history, symptoms, and behavior to make management decisions. Increasingly, sports medicine practitioners are treating patients with a diagnosis of mental health challenges. Although athletic training is not the primary mental health caregiver, they should recognize the signs and symptoms of common mental health conditions and be familiar with the range and the purpose of medications for treating patients with these conditions. While this course does not necessarily aim to provide specific medical advice, we want to focus on presenting information to help clinicians to better understand mental health disorders and the therapeutic medications used to treat mental health conditions. The athletic trainer should always consult with other allied healthcare professionals for diagnosis, treatment, and the management of patients with mental health conditions. The American Psychiatric Association Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or DSM-5, defines a mental disorder as a syndrome characterized by a clinically significant disturbance in a patient's cognition, emotional regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental process underlying mental functioning. In the United States, nearly 1 in 5 adults is diagnosed with a mental illness. Two broad categories can be used to describe these conditions: any mental illness, AMI, and serious mental illness, SMI. AMI encompasses all recognized mental illnesses and is defined as mental, behavioral, or emotional disorders. SMI is a smaller and more severe subset of all mental illnesses, such as dissociative disorder, obsessive-compulsive disorder, and personality disorders. SMIs are mental, behavioral, or emotional disorders that result in serious functional impairments that substantially interfere or limits one or more major life activities. Some examples might be mood or anxiety disorders, post-traumatic stress disorder, or eating disorders. A variety of mental health professionals are qualified to assess, diagnose, and provide treatment for patients with mental health concerns. Several National Collegiate Athletic Association or NCAA institutions have either incorporated a full-time licensed counseling or clinical psychologist within the athletic medicine or academic services department, or have established a mechanism for student-athlete psychological referrals as needed. Behavioral health emergencies. Patients who are experiencing severe changes in mood, thoughts, or behavior, or severe, potentially life-threatening adverse drug effects need urgent assessment and treatment. An athletic trainer must be able to identify when a patient's mood, thoughts, or behavior is highly unusual or disorganized, and is required to report if they have determined that the patient is a threat to themselves or others. A threat to self can include, but is not limited to, suicidal ideation or attempts, and self-neglect or failure to attend to the basic needs, including nutrition, shelter, and needed medication. As healthcare providers, athletic trainers are also required to report patients who pose a threat to others, those who are actively violent, those who appear to be belligerent and hostile, and those who do not appear threatening to the athletic trainer or staff members, but express intent to harm another person. Danger to others include the following: expressing homicidal intent, placing others in peril, or failing to provide for the needs or safety of dependents. When dealing with a patient who has expressed or indicated an intent or a plan to harm themselves or others, or an attempted suicide, the athletic trainer should not attempt to determine the seriousness of the thought, gesture, or attempt. Do not leave the vulnerable patient alone. Be familiar with suicide or poison control information and contact them immediately. Most college campuses have a counseling center staff member who can offer guidance or referral, and many counseling centers offer walk-in or emergency services. The treatment of mental health disorders is multifaceted. In some cases, long-term conditions require years of treatment. Unfortunately, the delay between the onset of symptoms and the treatment of mental health conditions can exceed 10 years. Complicating the issue is that two different patients with the same diagnosis may present with differing symptoms or respond differently to the same medication. Pharmacological intervention is a key component of mental health disorder care, but is not the only treatment regimen available to prescribers. A mood disorder is characterized by prominent and prolonged disturbances of mood that are generally inappropriate to the person's life situation. Depression and mania are considered the primary syndromes. Symptoms could include insomnia, suicidal thoughts, anorexia, and feelings of being a burden to others in people with depression and euphoria, irritability, decreased need for sleep, and hyperactivity in people with mania. Cases of intense sadness are termed depression, and intense elation is termed mania. Depressive disorders are characterized by depression. Bipolar disorders are characterized by varying combinations of depression and mania. Depression and bipolar disorder are the most common mood disorders encountered by athletic trainers in the sports medicine setting. Retired American football players who sustained concussion while playing are more likely to present with depression symptoms than players who have not been concussed. Symptoms may be summarized as common medical disorders, such as anxiety, depression, and sleep disturbances. Antidepressants are a viable treatment option, although psychotherapy may be preferred. A selective serotonin reuptake inhibitor, or an SSRI, is likely to be a first-line medication. If a change is necessary, a serotonin norepinephrine reuptake inhibitor, an SNRI, would be next, although tricycline antidepressants, or TCAs, would also be considered. When treating patients 48 hours after they have sustained a concussion, sports medicine physicians prescribe tricycline antidepressants 46% of the time, and SSRIs 24% of the time. Antidepressants are classified into different types depending on their chemical structure and mechanism of action. There are at least 7 different categories of antidepressants. Selective serotonin reuptake inhibitors, or SSRIs. These medications increase levels of serotonin in the brain by preventing its reuptake by the nerves. Common examples of SSRIs are Prozac and Zoloft. Women are more likely to have an adverse drug reaction and allergies than are men. Some of the risks associated with SSRIs include increased suicidal thoughts and seizures. When a patient abruptly discontinues or interrupts antidepressant therapy, they may experience discontinuation syndrome. Symptoms arising may vary with each antidepressant medication, but commonly include nausea, sweating, chills, tremors, paresthesia, and sleep disturbances. Patients should be closely monitored for clinical worsening and emergence of suicidal thoughts and behaviors. Mental health professionals should advise families and caregivers, such as athletic trainers, to closely observe the patient St. John's wort is a plant that grows in the wild and has been used to treat depression for centuries. The herb is a nutritional supplement sold in various retail and digital marketplaces. Unintended consequences could occur if a patient takes St. John's wort concurrently with some sedatives or hypnotics, such as benzodiazepines, because the herb can induce the metabolism of the drugs to the point that it can compromise the medication's effectiveness if taken simultaneously. Also, St. John's wort can increase the serotonin level, which places the patient at risk of developing serotonin syndrome, especially when the herb is taken concomitantly with other medications that cause serotonin syndrome, such as SSRIs. Anxiety disorders are among the most prevalent psychological condition worldwide. Generalized anxiety disorder, or GAD, panic attack, and panic disorders are anxiety disorders that cause nightmares, obsessive thoughts, and fear of leaving one's house. Anxiety refers to the presence of fear or apprehension that is out of proportion to the situation. Anxiolytics or sedatives are central nervous system agents that relieve anxiety, aid sleep, and have a calming effect. The main class of anxiolytics and sedative drugs are benzodiazepines or benzos. Although greater than 20 benzodiazepine derivatives exist, and some can be all three: anxiolytics, sedatives, and hypnotics. These medications carry a risk of addiction that may limit their long-term use. The most common side effect of benzodiazepines are related to their sedating and muscle relaxant action and include drowsiness, dizziness, and decreased alertness and concentration. With benzodiazepines, care must be taken to not overdose because they can cause dangerous deep unconsciousness. When combined with other central nervous system depressants, such as alcohol and opioids, the potential for toxicity and fatal overdose increases. Stressor-related disorders. Post-traumatic stress disorder, or PTSD, is a serious stressor-related disorder. This involves distressing symptoms that occur after one or more frightening incidences or traumatic events that affect a person's ability to function normally at home, at work, or in social situations. The DSM-5 describes a person with PTSD as one who has personally experienced or witnessed a traumatic event. The person may also have learned about violence to a close loved one. The event must have involved a serious physical injury or the threat of serious injury or death. Acute stress disorder, or ASD, is an anxiety response with some form of re-experiencing of or reactivity to the traumatic event. Symptoms develop within the first month after the traumatic event. In addition to various psychotherapeutic interventions that are recommended for the treatment of stressor-related disorders in at-risk people, several psychopharmacological recommendations exist. For acute stress disorder, SSRIs and other antidepressants are reasonable clinical interventions for the following reasons. They provide effective treatments for psychiatric disorders that are frequently comorbid with PTSD, such as depression, panic disorder, social phobias, and obsessive-compulsive disorder. They also may reduce clinical symptoms, such as suicidal, impulsive, and aggressive behaviors that often complicate the management of PTSD, and they have relatively few side effects. Military veterans returning from combat may have comorbidities of physical and emotional dysfunction. Conservative management of these physical conditions should include opiate therapy, and some patients may need surgery while using an SSRI to manage depression. Concurrent administration of surgical anesthesia and pain management medications could lead to serotonin syndrome, an adverse reaction that causes excessive serotogenic receptor activity in the central and peripheral nervous systems. This reaction enhances the depression symptoms secondary to PTSD. Athletic trainers must understand the comorbidities and polypharmacy involved in this type of case and advocate for other pain management options when a patient must undergo anesthesia. Sleep or wakefulness disorders. Almost half of all people in the United States report sleep-related problems. Although they are technically a neurological condition, sleep disorders are treated with drugs used for mental health conditions. Disordered sleep can cause emotional disturbances, memory difficulty, poor motor skills, decreased work efficiency, and increased risk of traffic accidents. It can even contribute to cardiovascular disorders and mortality. The most commonly reported sleep disorders are insomnia, excessive daytime sleepiness, sleep apnea, and parasomnias. Insomnia is difficulty falling or staying asleep, early awakening, or a sensation of unrefreshing sleep. Excessive daytime sleepiness, the tendency to fall asleep during normal waking hours. Sleep apnea, episodes of partial or complete closure of the upper airway that occur during sleep and lead to breathing cessation, defined as a period of apnea or hypoapnea greater than 10 seconds. And parasomnias, which is abnormal sleep related to events, such as night terrors or sleepwalking. The drugs to treat sleep or wakefulness disorders are typically hypnotics. Hypnotics are prescribed for patients who need rapid relief and who have insomnia with daytime effects such as excessive daytime sleepiness and fatigue. In most cases, these drugs do not need to be used indefinitely. Hypnotics differ primarily in the elimination half-life and the onset of action. Drugs with a short half-life are used for sleep-onset insomnia. Drugs with a longer half-life are useful for both sleep onset and sleep maintenance insomnia. Patients who experience daytime sedation, incoordination, and other daytime effects should avoid activities that require alertness, and the prescriber should adjust the dose or stop the use of the drug. Other adverse effects include amnesia, hallucinations, incoordination, and falls, which are a significant risk when taking hypnotics. Attention deficit or hyperactive disorder. Attention deficit or hyperactivity disorder, ADHD, is a persistent pattern of inattention or hyperactivity and impulsivity that interferes with the functioning or development. ADHD is not clearly defined or diagnosed in adults as it is in children, but it presents as a combination of problems relative to the attention span or impulsive behavior, among other traits. Adult ADHD can lead to low self-esteem and poor work performance and may interfere with daily functioning and maintaining stable relationships. Adults who have been diagnosed with ADHD also present with comorbidities. 30 to 50% also have depression and 40 to 60% have anxiety. The treatment of ADHD can involve medication and psychotherapy. For adults with ADHD, the pharmacological approach involves stimulants and non-stimulants that are available in a variety of different formulations, including patches and extended-release products. The stimulant approach for adults has a 70 to 80% response rate, and the medication alleviates difficulties with attention span, impulse behavior, hyperactivity, and restlessness. NDRIs, such as Ritalin, is historically the first line of treatment. It is absorbed rapidly, and it has a first-pass hepatic metabolism. Mixed amphetamine salts. These are central nervous system stimulants that affect the chemicals in the brain and nerve cells that contribute to hyperactivity and impulse control. Eating disorders. Eating disorders involve a persistent disturbance of eating or behavior relating to eating that alters the consumption or absorption of food significantly and impairs physical health or psychological functioning. Disordered eating is best conceptualized along a continuum of pathogenic eating and weight control behaviors that encompass a full spectrum of clinical and subclinical classifications. Disordered eating is the preferred term when references are made to the entire spectrum of abnormal behaviors, whereas the term eating disorder is preferred when there is a definitive clinical classification of abnormal behaviors. The National Athletic Trainers Association provides guidelines for creating the necessary team infrastructure, collaborative relationship, and strategies for preventing, detecting, and managing patients with disordered eating. Athletic trainers should have a knowledge of the psychotropic medications that are commonly prescribed to treat the symptoms that accompany with eating disorders, including their potential side effects. They should also be able to recognize symptoms of missed doses or overdoses. In general, the treatment of anorexia nervosa may require life-saving, short-term interventions to restore body weight. Medications for anorexia nervosa typically include antidepressants for treatment of persistent depression or anxiety following weight restoration. Results are best in adolescents who have had the disorder for less than 6 months. For bulimia nervosa, in addition to the psychotherapy treatments that are helpful for depression, anxiety, obsession, and certain impulse disorder symptoms, prescribers may also consider SSRIs, which have the most evidence for efficacy and the fewest difficulties with adverse effects. Dosages may need to be higher than those used to treat depression. Typical side effects include insomnia, nausea, and sexual side effects. Substance use disorders involve a pathological pattern of behavior in which patients continue to use a substance despite experiencing significant problems related to its use. There may also be a physical dependency or manifestations, including changes in brain circuitry. The common terms addiction, abuse, and dependence are too loosely and variably defined. Substance-related disorders involve drugs that directly activate the brain's reward system, which typically causes feelings of pleasure. The specific pleasurable feelings evoked vary widely depending on the drug. The treatment of substance use disorders varies depending on the substance and the circumstance. In addition to psychosocial treatments or behavioral therapy, pharmacological treatments may be helpful for select patients. There are drugs that help discourage alcohol use, discourage nicotine cravings, and may reduce withdrawal symptoms of opioid use disorder. In summary, mental health disorders affect a significant percentage of the population. In addition to treatment options such as the initial support and psychotherapy, pharmacological interventions are an effective approach for many patients. Sports medicine practitioners have many patients who have been prescribed these medications following a concussion or secondary to an athletic injury that led to depression or anxiety. These patients or others exhibiting signs or symptoms of mental health disorders or a behavioral emergency should be appropriately referred to a mental health professional. In some cases, patients may need multiple medications. In other cases, patients with similar diagnosis will respond differently to the same medication. Risks are associated with these medications for mental health disorders, and providers must monitor patients. Athletic trainers should be aware of the black box warnings relating to suicidality and the antidepressant drugs, as well as the risk of misuse and abuse of amphetamines.